So, hello everyone and welcome to this gas paper series. Today's subject is anatomy and I am Dr. Ankit, your anatomy faculty at Next. So, in this session, we'll be discussing the few important PYQs and the few important probable questions that might come in the upcoming FMG exams. They're high probability questions. If not, then obviously the topics are very important. So, I would urge all of you to kindly pay attention and whatever you think about the option, do write in the comment box so that I can reply to it and let's see how it goes. So here's the first question over here. A 40-year-old female with breast cancer was taken for radical mastectomy and axillary lymph node dissection. A few weeks after surgery, she presents with a weakness in overhead abduction and winging of the scapula, which nerve is likely to be injured. So I know that most of you, the moment you must have seen the word winging of scapula, it must have been running to your minds like it's a damage to the long thoracic nerve, and that leads to the paralysis of serratus anterior, right? So yes, the answer over here is what? The answer over here is the long thoracic nerve. But there are a few other things which we should keep in mind. Over here, the case is of breast cancer and that she was undergoing a surgery. So obviously the axillary area was being dissected. Is this nerve related to the axilla? The answer is yes, it is related to the axilla. It is found in the axilla. Therefore, this nerve could be injured. Is there any other nerve that could be injured apart from the long thoracic nerve? The answer is yes. Other nerves could be intercostobrachial nerve, or it could be the nerve to latissimus dorsi, that is also known as your thoracodorsal nerve. So that could also be injured. But here in this question, they asked about the long thoracic nerve and the serratus anterior. Now, if you look at the findings, winging of scapula, we already know it is due to the long thoracic nerve. But why weakness in overhead abduction? The reason is that the overhead abduction is done by mainly two muscles, and these two muscles are what? These two muscles are, first of all, is your serratus anterior only, and the second one is the trapezius. Therefore, if you have this paralysis of the serratus anterior, that will lead to weakness in the overhead abduction. So finally, we are confident that okay, this is the answer. But mind you, that option number A and C, they also could be injured in axillary dissection. Right, now here's a couple of images. This over here is showing us this muscle over here, that is serratus anterior. This is the P minor, pectoralis minor, and this huge muscle is the deltoid. And this area over here, this is the area that is the axilla, right? Serratus anterior forms the medial wall of the axilla. And therefore, the nerve that would be running like this over here would be the long thoracic nerve. Let us see a couple of more images for better clarity. These are all the axillary lymph nodes which were actually being dissected for that CA breast. And that led to the damage to this long thoracic nerve, which you can see over here, that was passing on the medial wall of axilla. Fine, fair enough. Let's see the next question, long question. But remember always, in a long question, on whichever subject it is coming, try to read the last 2-3 lines first of all. So if we just randomly start reading from this diagnosis word, diagnosis of cavernous sinus thrombosis is made, which of the following does not pass through the lateral wall, does not pass through the lateral wall of the cavernous sinus. Now see, just by reading not even 2 lines, we know that what the question is being asking us, which is not passing through the lateral wall of cavernous sinus. Okay, and therefore we all should be knowing that lateral wall of cavernous sinus helps in the passage of nerve number 3, nerve number 4, V1 ophthalmic nerve, and V2 maxillary nerve plus or minus. But 3, 4, V1 are always present over there. Now, if you just go through the question, read the whole question. The 45-year-old diabetic and hypertensive presented with painful and swollen right eye. He had fever. A day prior to symptoms, he burst a furuncle to the outer margin, the dangerous area of the face, the lower nostril and the upper lip. On examination, the eye movements are painful, and on observation, there was marked edema because there was venous congestion. So the question is that which structure is not present in the lateral wall? So which are present, we have seen. So let us see, oculomotor is present, ophthalmic is present, trochlear is present. So abducens is not present in the lateral wall. Therefore, this would be the answer. And the question arises that where is abducens nerve actually located? Is it related to the cavernous sinus? The answer is yes, but where? It is present inside the cavernous sinus. That we'll see in the image as well. So here is the image showing us what? The dangerous area of the face. Okay, so this is the dangerous area of the face. Why? Because if you burst any furuncle or any infection or thrombus from here might go back through the veins into the cavernous sinus. So what will be the route which we can see in this image? So here you can see in this image that is the anterior and the posterior part. And here you have the superior ophthalmic vein, the inferior ophthalmic vein, and the pterygoid venous plexus, the deep facial veins. All these might lead to the thrombus into the posterior aspect wherein the cavernous sinus over here. So from all of this, the thrombus might go into the cavernous sinus, leading to its thrombosis. And if we look at the coronal section of the cavernous sinus, we see over here that this is the lateral wall of cavernous sinus, having third nerve, fourth nerve, V1 and V2. And where's the sixth nerve? This over here is the sixth nerve that was asked. It's not lying in the lateral wall, it's lying inside the cavernous sinus along with the internal carotid artery over here. Okay, so the topic is cavernous sinus thrombosis, quite important. Here is an image of a patient with a cavernous sinus thrombosis. You can just look at the image. The swollen eyes, why? Because of venous congestion. Painful eye, why? Because of V1 involvement. Ophthalmic is sensory nerve. Why there's ophthalmoplegia? Because third nerve, fourth nerve, sixth nerve are involved, so there's ophthalmoplegia. The eyeball cannot move, and the moment they try to move, it's a lot of pain. Next question. A 55-year-old lady is diagnosed with the nasopharyngeal carcinoma, head neck question again, that has spread to the sinus of Morgagni. Which of the following structures will be affected due to the spread in the sinus of Morgagni? Now here, you should be knowing, only then you can answer that. What is sinus of Morgagni? It's a space in the upper part of pharynx between what? Between you have the base of a skull over here, and below you have the muscle which is the superior constrictor over here. So between these two, you have a space that is known as sinus of Morgagni. And they are lying where? Actually, they are lying just behind the nasopharynx. So you have the nasopharynx over here, and just behind you have this structure known as the sinus of Morgagni. Question comes at what structures are there in the sinus of Morgagni? So structures over here, remember, there are few vessels. Like what? You have the ascending palatine artery. You have the branch from the ascending pharyngeal artery. Then you have that tube which connects the middle ear to the pharynx. What is that tube? Eustachian tube. And then there are muscles which are around the eustachian tube to open it. Those muscles are from the soft palate. The moment we swallow, the eustachian tube opens, so that there is equalization of the air pressure in the middle ear and the environment. Those muscles are basically levator palatini and tensor palatini. Okay, so these are the contents in the sinus of Morgagni. Therefore, look at the question, and if you start looking for the answer you can see is option number A. That is the answer. Other options over here like glossopharyngeal nerve, these all are present where? They are present below. They will be present below the sinus of Morgagni, below where? Between the superior middle constrictor, or between the middle inferior, or below inferior constrictor. That we'll see. So therefore, come to this image. Here all the three constrictors are shown. This is the anterior aspect, that's the posterior aspect. These constrictors are basically the muscles of pharynx. Remember it. They help in the peristalsis of whatever we swallow from the pharynx. Now if we take a coronal section from here, if we take what? If we take a coronal section from here, you can see the base of skull, and those are two sides, the right and left side. Here kindly focus on the muscles, superior, middle and inferior constrictors. And here also, if we look at the muscles, superior, middle and the inferior constrictor. What they asked in the question was, this is the space or the sinus of Morgagni. You can see the structures lying over here. Eustachian tube, levator palatini muscle, ascending palatine artery, all of this. Now, other options were, if you recall, were our glossopharyngeal nerve, right, stylopharyngeus muscle and recurrent laryngeal nerve. They are present below the superior constrictor, not in the sinus of Morgagni. Only this part is known as the sinus of Morgagni. Okay, that's the whole point. Let's see the next one. During neck dissection, a surgeon accidentally injured the hypoglossal nerve. The poor patient. So the tongue is paralyzed, sort of, right? Which of the following triangles of the neck is he probably dissecting? Think about it. The hypoglossal nerve was damaged during neck dissection. The reason could be anything, could have been any reason for the surgery, but hypoglossal nerve is damaged. Now, as a student of medical science, we should know about the basic anatomy. This nerve could have been damaged where, in which triangle? So this nerve lies in which triangle of the neck? Is it the muscular triangle? Muscular triangle, see, it lies anteriorly. I'll show you the image as well. They have the stap muscles. Is it the carotid triangle? Carotid triangle having that carotid sheath. Could be. Posterior triangle is actually behind, between the sternocleidomastoid and the trapezius. Submental triangle is right over here. Therefore, if you just go with the common sense, it looks like, okay, carotid triangle could have been the answer, my best bet. But let us see an image over here. Okay, this is the area for the carotid triangle. If I just highlight it like this, other triangles were muscular, occipital, and this was the submental triangle. So hypoglossal nerve actually passes like this. It has to go into the tongue, right? And it makes a loop around one nerve. Can you name that nerve? I'm asking. The hypoglossal nerve makes a loop around one artery. Nerve makes a loop around one artery. That artery is a lingual artery. It is a branch of the external carotid artery, again lying in the carotid triangle. So here's an image showing us these things. This area is the carotid triangle, and this is where you can focus about the lingual artery and the nerve going about it, hypoglossal nerve. And this nerve could have been damaged over here. In which triangle? In the carotid triangle. Right? So remember, the answer for this is obviously the carotid triangle. Okay, hypoglossal nerve lies in the carotid triangle, and then it enters from behind into the tongue, below the lingual nerve. Right? Fine. The next question. A woman visits the gynae and complains of UTI and vaginal pain. The patient feels a burning sensation during urination. That is, I guess, one of the most prominent symptoms of having UTI. An increase in the frequency, again, important sign symptom. A pelvic examination is conducted and a vaginal sample is taken. What is the normal lining epithelium of vagina? Think about it. Don't look at the options, just open your mind. Lining of vagina opens outside, right? So it has to be stratified squamous epithelium. Any structure that is opening outside on the environment or on the skin has to have a stratified squamous epithelium. Take the nasal mucosa, the oral cavity. Now, vagina has mucosites, wet, so it would be non-keratinized stratified squamous. The skin is keratinized stratified squamous. So, columnar no, keratinized no. Answer is option number D. Has to be non-keratinized. Yes, it is. Think about it. Even they ask you the oral cavity, go with this. Esophagus, go with this. Right? So think about it. Why the answer is non-keratinized stratified squamous epithelium. A question from the upper limb. The physician exacerbates, that is, increases the wrist pain by applying pressure to the base of the thumb as seen in the photo. The radiographic imaging will confirm the break of which carpal bone? Look at the photo. It is lateral or the medial side of the wrist? It is obviously the lateral side. It is the thumb side. That is the medial side, right? What carpal bones lie over here? So if you know, there you have the scaphoid, lunate, triquetral with the pisiform, and then you have the trapezium, trapezoid, capitate, and hamate. These are the 8 carpals going from lateral to medial. So in this area, which carpals are there? These lateral carpals, the scaphoid, right? The trapezium, all these are present. Which is commonly or most commonly fractured carpal is the scaphoid. Therefore, answer is our scaphoid. Right? Answer is our scaphoid only over here. Okay, so therefore answer is scaphoid simply. And here you have an image, a radiographic image for the hand bones, and here you can very easily see that this is the lateral side, because thumb side, that is the medial side, and this is the culprit over here, the scaphoid. Okay, here it was impressed and the scaphoid is over here, most commonly fractured. The most commonly dislocated is probably the lunate, that is normally dislocated. Okay, here you can see another image showing us again, this is the scaphoid fracture. This is the fracture scaphoid over here. This is the radius, that's the ulna, that is the lateral, that's the medial side. Let us label all the bones over here: scaphoid, lunate, triquetral, over which pisiform is sitting. Then you have the trapezium, trapezoid, capitate, and hamate over here. Okay, fair enough. So next one, a 26-year-old lady comes to the physician for a follow-up examination 1 week after undergoing a rotator cuff repair surgery. Okay. Physical examination of the right shoulder shows a decreased sensation to pinprick and light touch over the lateral shoulder. Okay. Decreased sensation to pinprick. So decreased pain and touch over the lateral shoulder. Lateral shoulder is decreased. There is normal passive range of motion of the shoulder, but she has difficulty in externally rotating, that is the lateral rotation, and abducting her right arm. So difficulty in lateral rotation and abduction of right arm with the decreased sensation on the upper shoulder. These are findings. Which of the following structure was most likely injured during the surgery? Surgery was done where? Surgery was done over the rotator cuff. Rotator cuff, basically you have the supraspinatus, infraspinatus, all those muscles over here. some nerve is damaged over here. Think about it, which nerve it could be. Obviously, decreased sensation of upper shoulder, regimental badge sign, remember. I hope most of you must have got the answer by now. The nerve is obviously the axillary nerve, but let us see the other findings. Difficulty in lateral rotation and abduction. Now tell me which muscle causes lateral rotation of the shoulder. This is the lateral rotation. You have mnemonic was LRTI. Lateral rotation by T and I. T and I are what? T is minor and I is for infraspinatus. And abduction is basically the main abductor muscle is deltoid. Now if you look over here, the deltoid, the teres minor supplied by which nerve? This axillary nerve. And the same sensory loss is due to the axillary nerve. Therefore, we are confident that axillary nerve is having problem. And also do remember that this axillary nerve lies where? It lies just deep to this area for the rotator cuff, upper shoulder area. Because it could have been damaged over there. Here is an image. What is this image trying to show us? It's a posterior shoulder. It's a posterior view from the shoulder area. And remember, this is the D for deltoid. Those are the teres major, and that is the teres minor. And here you have the long head of triceps. But think what we are trying to show you over here is these are the few spaces over here. These are the few spaces over here. If you remember, the spaces were named as quadrangular space, the lower triangular and the upper triangular space. Where is the axillary nerve? The axillary nerve is located in the quadrangular space. We have the axillary nerve along with the posterior circumflex humeral vessel. Posterior circumflex, and you can see it's very close to the upper shoulder. What is present in the lower triangle? The main content over here is the radial nerve. It passes behind into the spiral groove along with the profunda brachii vessel, And what's present in the upper triangular space? You have the circumflex scapular vessels. So here the question was about this axillary nerve, so remember this, right? Next question, while walking to his classroom building, a first-year medical student slipped on the wet pavement and fell against a curve, injuring the right arm. Radio images shows a mid-shaft fracture of the humerus. Which pair of structures was most likely injured at the fracture site? Remember, in the mid-shaft fracture of the humerus, the most common nerve to be damaged is the radial nerve. We have just seen. It passes behind the radial groove along with the structure that is a profunda brachii vessel. The profunda brachii is a deep, also known as a deep brachial vessels. Now, these structures could have been injured. Let us see the options. Yes, you have the option number C over here, the radial nerve, the deep brachial artery. They are basically asking us in the mid-shaft fracture, which structure could be damaged? You have the spiral groove structures that could be damaged, and these are the contents of the spiral groove. Okay, right, here you can see the images, the course of the radial nerve probably. So here is an anterior view, understand it, anterior from the front. You see the radial nerve, the largest branch of brachial plexus is coming from the posterior cord of brachial plexus, right from here, behind the, you can see the axillary artery. And then it vanishes right over here because then it runs posteriorly. Posteriorly where? In the radial groove. Here you can see radial nerve lying in the radial groove. And radial groove is actually part of so when the radial following it's very simple, keep it simple. So this area is what? This is a radial nerve. Here you have the ulnar nerve. This is basically radial nerve branch. Which branch of radial nerve? The superficial branch of the radial nerve, which is entirely cutaneous. So here this is the radial nerve. That will be our answer. Sir, why not D? It is also a branch of radial nerve. Yes, you are right. It is a branch of radial nerve, no doubt about it. It is a branch of radial nerve. But the point over here is this is actually entirely motor nerve. What muscles does it supply? This supplies all the extensors of forearm. It supplies all the extensors of forearm. Here you have the image of the dermatomes. Go through it, but look over here. That is the palmar aspect, that is the dorsal aspect, and this is what they asked. And this color you can see, if I highlight it, was our probably best answer over here. Right? Okay. The next one, muscle attached to the area marked in the figure below. You can see this figure. Try to identify what part are they showing us. This is a humerus, and these are two forearm bones. Now, this is which bone? Is it radius or ulna? Trace it superiorly. You can see this head over here. This is radius over here. And below, you can see this huge olecranon. This is the ulna over here. So the arrow is towards the radius bone, having a radial tuberosity. They are asking muscle attached to the area marked. So what muscle is attached to the radial tuberosity? That's the whole question. Muscle attached to it is our biceps brachii. So biceps brachii is the muscle that is attached to the radial tuberosity. And what does it do? It is flexor of the forearm plus supinator. So the function of it is flexor of the forearm and supinator. It is a very important supinator. Brachialis goes to the ulna bone. Okay. Brachioradialis goes from the lower end of humerus to the radial styloid process. Now that is located where? It is located at the inferior, the lower part of the radius bone. Long head of tricep, now they will go to the olecranon process, which is present in the ulna. Right? So therefore answer is option number A. Okay, which of the following nerves are related with the marked structures? You all can identify the bone. I'm sure the hip bone over here. What is the marked structure? Identify the hip bone. See, in hip bone, you see few things like this, the obturator foramen. Fine. This over here is the iliac crest. Fine. This over here, which is star marked, they're asking, this is what? This is the ischial spine. This is the ischial spine over here. Above it, you have the greater sciatic notch. Below, you have the lesser sciatic notch. What is in front? This is, if I ask you, from ASIS to pubic tubercle, there's a structure that lies over here. If I ask you, there's a structure that lies, can you name that structure? It's a remnant from the external oblique epineuritis. This is our inguinal ligament. So, just a brief idea now. They're asking about which nerve is related to the ischial spine. That is present posteriorly, that is anterior aspect. Now here you have a very important nerve that actually goes from pelvis via greater sciatic notch, then it goes just behind the ischial spine, then it comes back into the perineum, which is this nerve. This nerve over here is our pudendal nerve, where the pudendal block has been given. So answer over here is the pudendal, option number B. Pudendal is coming from the sacral plexus over here. This over here is the sacral plexus. This is the sacral plexus over here. Pudendal nerve over here having the root value of S234 is what they asked. It is the main nerve which supplies the perineum, the muscles as well as the skin in the perineum, which includes both our anal triangle having the ischio-anal fossa and the urogenital triangle having the perineal pouches. So understand, this nerve is very important. This nerve is very important, right? And is related to the ischial spine, where the pudendal block is being given while doing any surgery or any manipulation in the perineum region. Okay, so it actually, if you give a block to the pudendal nerve, those areas obviously will be anesthetized and you can do whatever procedure you want to do in the perineum area. But remember, you have to do it on both the sides, right? Or not on just one side, on both the sides, obviously. While on a neurology rotation, the attending physician asks you to test the patient's which nerve? Femoral nerve function. What would you do? Simple question. How to test a femoral nerve? Now, femoral nerve supplies which compartment of the thigh? We have three compartments: anterior, posterior, and medial. Femoral nerve is responsible to supply the anterior compartment. Anterior compartment, which muscles do they have? They have the quadriceps femoris. What do they do? If you just straighten your knee, you will feel the contraction of the quadriceps femoris. So they do what? They extend the knee. They extend the knee. All the patients having this slightly pain in around knee, the old age, the degenerative osteoarthritis, the physiotherapist will always ask them to exercise about this muscle, quadriceps femoris. So it does this supplied by the femoral nerve. If you look at the options, option A, have the patient flex his knee. Flexing the knee, no doubt it's a good exercise, but flexing the knee will you're testing which compartment of thigh? You're testing the hamstrings. They are in the posterior compartment, not a function of femoral nerve. Having the patient to rotate the thigh medially while you resist. Again, rotation of thigh, medial rotation of the thigh is basically done by the glutes, the gluteus medius or minimus. Again, not femoral nerve. Extend the thigh against resist. Now see, extension of thigh and extension of the knee are different. When we say extension of the thigh, listen to my words very carefully. They are basically referring to extension at the hip joint. Now, which muscle causes the extension of the hip joint? It's the G max, gluteus maximus. And which nerve supplies it? It's the inferior gluteal nerve. Obviously, now we are left with the last option. That should be the answer. Having the patient extend the knee against your resistance. That we have just already witnessed. How? That's a function of the quadriceps femoris. Quadriceps femoris, not quadratus femoris. Therefore, D is the answer over here. Next question again. As part of a physical examination, to evaluate the lower limb function, a physician asks her patient to stand on the tiptoes as shown. What nerve is the doctor testing? See over here. Look at the image only. Standing on the toes, which leg compartment is being stimulated, or which is the leg muscles, or which compartment of the leg muscles are being contracted? Where is the movement occurring? Movement is occurring at which joint? Ankle or knee? Movement is occurring at the ankle joint. Okay, fair enough. What is the movement occurring at the ankle joint? Is it dorsiflexion or plantar flexion? The movement is plantar flexion. You can very well see this is a plantar flexion. Okay, the plantar flexion will be done by which compartment muscles of the leg? Anterior, posterior, or the lateral? It is done basically by the posterior leg muscles with the calf muscles. Can we see the contraction? Yes, very well. Look over here, the tightness of the calf muscles. Right? Posterior leg muscles supplied by which nerve? They are supplied by the tibial nerve. So the moment you stand on your toes, basically you are testing the tibial nerve. That is the answer. See how easily we reached out. Simply look at the movement. If any doubt, do it on yourself. See which compartment of muscles are being contracted. If the anterior leg, they ask about the anterior leg muscles, the nerve supplying there is a deep peroneal nerve. The lateral leg compartment is superficial peroneal nerve, and the posterior leg, we have seen it's a tibial nerve. So remember these basic things over here. Next one, a 7-day-old newborn with the diagnosis of a patent ductus arteriosus. Remember, this is present between which vessels? It is present between the arch of aorta and which artery? The left pulmonary artery. Okay, so it remained patent. So 7-day newborn with a diagnosis of PDA undergoes surgery to ligate the ductus arteriosus. During the repair, the surgeon takes special care to avoid injury to a closely related nerve. So surgeon is protecting which nerve? So which nerve is around that ductus arteriosus? If you see over here, you have this arch of aorta, and you have this huge pulmonary trunk giving off the left pulmonary artery and the right pulmonary artery. The pulmonary artery goes then behind the arch and behind the SVC. If I may just show you, this will be our SVC coming down. So right pulmonary artery, you can see it goes behind the aorta, behind the SVC. Fair enough. Here what we have, this is the ductus arteriosus. This is the ductus arteriosus. Now which nerve is over here? That is what they're asking. There has to be some nerve going around it, right? The nerve over here, this is the left-sided vagus nerve. So is that the answer? No. The left vagus will run through, but it gives off over here a branch which is exactly running beneath the ductus arteriosus, that is left recurrent laryngeal nerve, which will go to the larynx. Answer over here, therefore, is not the left vagus, is the left recurrent laryngeal nerve, right? Remember, this is very, very important question. Embryology also of this is very important. Right, next one. As a surgeon exploring the thorax, you will be able to identify the right pulmonary artery in which of the following location. If you are paying close attention, I just told you in the previous question only, where would the right pulmonary artery go? Let me show you the image. Look at the image. Identify the right pulmonary artery. It's going where? And then try to answer this. Is it anterior to ascending aorta and SVC? Posterior to ascending aorta and anterior to SVC? Posterior to descending aorta and SVC? Posterior to ascending aorta and SVC? Answer. It is, or it was, as I told, posterior to ascending aorta, and it was posterior to SVC as well. Because it has to go to the high lung of the right lung. SVC has to come to right atrium. It's more anterior. Right? The answer is our option number D. Answer is our option number D. Very important question over here. Right? 54-year-old lady is admitted to the hospital with a stab wound of the thoracic wall in the area of the right fourth costal cartilage. So we have the sternum, the manubrium, the body, and the xiphoid. We have the first rib, the second, third, the fourth, the fifth, the sixth, and the seventh. So here we have where? This is the fourth one. So stab wound is where? Right fourth costal. This is the area for the stab wound. Which of the following pulmonary structures is present at this site? Is it the oblique fissure of the right lung, horizontal fissure of the right lung, root of lung, or apex of right lung? See, what happens is the the lungs, if you look at the lungs over here, normally the right lung might look like this, the left lung might look like this. The root of the lungs are over here, the apex are obviously at the top. But what is exactly over here? Understand, we have the, remember, 4, 5 and 6. 5 over here, 6 over here, and 4th cartilage over here. These are the landmarks for the middle lobe of the right lung, right? And this over here is the horizontal fissure, and this is coming from behind, that is the oblique fissure. So at the right 4th costal cartilage, we have the horizontal fissure of the right lung that is running. Okay, this is the horizontal fissure of the right lung, which will be our best answer over here. A 48-year-old lady had been scheduled for cholecystectomy, that is removal of the gallbladder. During the operation, the scissors accidentally entered the tissues immediately posterior to the epiploic foramen. The surgical field was filled immediately by profuse bleeding. Which vessel was most likely source of bleeding? So they are asking this question that do you know the boundaries of epiploic foramen, or do you know anything about the epiploic foramen? Let us see. You have this as the lesser curvature of stomach, the greater curvature of stomach, the duodenum over here that goes down. And here what you have, here we have the lesser omentum running like this. It goes from stomach to the liver. So liver will be present where? Over here. Epiploic foramen is present just behind the right margin. This is the area for epiploic foramen. So what are the boundaries of it? Boundaries of it are, if we look over here, the boundaries, we have an anterior boundary, we have a posterior boundary, we have a superior boundary, and we also have an inferior boundary. Think what would be where? Anterior the epiploic foramen, we have the portal triad in the lesser omentum. Posterior, we have a very huge vessel IVC lying at T12 vertebrae. Above, we have the liver, basically the caudate process of the liver. And below, we have the first part of duodenum, as you can see over here, below, above, in front, behind. Now they're asking the question that the scissor went where? Posterior. Posterior lies what? Posterior lies the IVC. The T12 bleeding is obviously with the IVC. Answer is IVC. Answer is definitely IVC, right? So boundaries are epiploic foramen. Now gastric contents exiting the posterior perforation of the stomach wall will accumulate. They're asking that, okay, this is the stomach, there was an ulcer or anything, and it perforated posteriorly behind. So the gastric contents, if there is a hole in the wall of the stomach on the posterior aspect, so the contents inside the stomach will reach which space, or which space lies behind the stomach. Basic knowledge should be over here. The space lies behind the stomach is the lesser sac, also known as omental bursa, and therefore this would be one of the options should be like this, and which are A, B, C, D. D is the answer over here, omental bursa. Let us see an image as well. Here you can see that's the anterior part, the posterior part, the left part, and the right part. So here we have the stomach over here, and this is the space which they are referring to, behind the stomach. So perforation from here, contents go here. What is this? Lesser sac or omental bursa. Remember this. Okay. You are at a surgery and are about to mobilize the second portion of duodenum D2 and the head of pancreas. Fine. We all know that, okay, this is the first part duodenum, second part, third part, and fourth part. And over here also lies the pancreas going into the spleen, towards the hilum of the spleen, right? Now you are about to mobilize which areas? The second part duodenum and the head of pancreas. Okay. You note an artery and a vein passing anterior to the uncinate process and third portion of duodenum. So you have identified some artery and vein running over here. Which veins, which vessels are those? So always do remember, here you have an artery running down, and to the right of it you have a vein running down, and these are coming from or going towards the midgut. They are known as the superior mesenteric vessels. So questions come in various forms. Doing a surgery over here, which vessel is involved? It is always going to be superior mesenteric vessels, option number A over here. Let us see the help of an image as well. This is what they actually asked. This is what superior mesenteric artery, and to the right of it superior mesenteric vein. But do remember other structures. Let me highlight. Splenic artery, superior border of pancreas, right? Gastroduodenal artery, okay, just behind the duodenum, and at the upper part of the head of the pancreas. Okay, splenic vein not clearly shown in this image, but let me try to show you. This splenic vein runs behind the pancreas. This is the S dot vein, splenic vein, and superior mesenteric vein will meet with it, and the portal vein is formed over here, again behind the neck of pancreas. Let me write over here, that is the portal vein. So it's very, very important. Where does it lie? Behind the neck of pancreas. So remember that too, must know. Okay, so all the structures lying, the relations around it. Next question, a 44-year-old man is admitted to the emergency with excessive vomiting and dehydration. Radio images demonstrate that part of the bowel is being compressed between the abdominal aorta and superior mesenteric artery. Superior mesenteric artery itself is the branch of aorta. They are saying some bowel is being compressed. Let us see. Which of the following is most likely being compressed? Now, if you look just at the previous image, this is the superior mesenteric artery. It is coming from behind, from the abdominal aorta. Now, if I ask you, okay, tell me which part of the gut is probably over here, what will you answer? Remember this, right? That was the 4 parts of the duodenum, and also do remember about the pancreas over here. So this is which part? This is which part? That is the 3rd part of duodenum. So if the artery is coming down like this, so it might compress which part of the bowel? The 3rd part of duodenum. Therefore, the answer over here will be our 3rd part of duodenum. This will be our answer. Let us see an image as well. This is a lateral view having this anterior and a posterior aspect. Remember, this is the abdominal aorta, and this is the superior mesenteric artery coming down. So what lies at the angle between the aorta and the superior mesenteric artery? It is this left renal vein, not the artery, it's a vein. Artery is this is the artery. The left renal vein, it is the 3rd part of duodenum. These 2 main structures. Along with, sometimes you may also have the uncinate process of pancreas as well. So remember 1, 2 and 3 at least. These are all the 3. And that is known as a superior mesenteric artery syndrome, SMA syndrome, also known as the nutcracker syndrome. That's also known as the nutcracker syndrome. Very important question. Next one, a 67-year-old presents with the shingles, so herpes zoster. On his left forehead, as you can see, upper eyelid, okay, and a bridge of the nose, okay. What sensory ganglion? So shingles, you all know, is from the reactivation of the herpes zoster from the dorsal root ganglion of the sensory nerve. Now, if you look at the face, the sensory nerve of the face is which one? Trigeminal. And this area of the face is from which branch of trigeminal? It's the ophthalmic division of the trigeminal, or the V1, also known as V1. Therefore, answer has to be the ophthalmic nerve. But they're asking what sensory ganglia. So what is the trigeminal ganglia, also known as? The different names could be semilunar ganglia, but here they have given the option simply as trigeminal ganglia. So we'll go with this simple, straightforward question. If you look at the other options, otic is a parasympathetic ganglia. Ciliary ganglion is a parasympathetic ganglia. Superior cervical is a sympathetic ganglia. So obviously, if you rule out, also come to option number B only. Here's an image again showing us the trigeminal sensory map, and this is where the shingles actually came to that patient in the left forehead, upper eyelid, and the bridge of the nose. This is the area of ophthalmic nerve. Remember. Okay, the next one over here, the 42-year-old lady complains to the physician about recurring episodes of sharp pain that seem to originate from around her mouth and cheek. The pain is so intense that she is unable to eat, brush her teeth, or apply the makeup. Which of the following cranial nerves is most likely to be the source of this pain? This is a typical case of dash neuralgia. It's a case of trigeminal neuralgia. Obviously, the trigeminal nerve is the one that is involved over here. A typical case of trigeminal neuralgia. Very important for the old age patients. Mainly arises from V2 or V3. Okay, fair enough. Now, 28-year-old is admitted to the hospital for the evaluation of a symmetric ascending weakness, okay, that started in his feet and has become progressively worse over the past 5 days. A lumbar puncture is performed to confirm the diagnosis. As the needle advances during the procedure, there is some resistance just before entering the epidural space. The resistance is most likely to by which of the following structures? So the LP is done to take out the CSF. CSF is where? In the subarachnoid space. Now think about it. we have this, imagine as the CSF over here. Just imagine it is present with subarachnoid space. Fair enough. So imagine this is the arachnoid layer. This is a arachnoid matter, AM. Right? So you have a dura, arachnoid, and pia matter, right? Above it, we will have what? You will have the dura matter. Okay, fine. Imagine this as to blue color as the dura matter. Now they are saying, now above the dura matter, which space will be over here? Above the dura matter over here, which space will be? The epidural space. This area for the epidural space, where you have the veins as well as some fats also. They are saying that as the needle is advanced during the procedure, there is resistance just before entering the epidural space. So as the needle was coming to the epidural space, at some point over here, they felt a resistance. Think about it. Is it ligamentum flavum, supraspinous, intra, or dura mater? See, it can't be dura mater because dura is obviously deep about it. Resistance felt before entering the epidural space. Supraspinous and intraspinous, they are present in the spine of the vertebrae. The ligamentum flavum is the answer over here. The reason being that ligamentum flavum is actually covering the laminas. It is around the laminas of the vertebrae and just present over the epidural space. If you look at the vertebrae over here, so imagine this is the body of the vertebrae. That is the pedicle, the lamina, and the spine over here. Okay, and the transverse process going on the outside, anterior, posterior. Let me label it: body, pedicle, lamina, spine, and transverse process. The ligamentum flavum will be present where? Right over here, right over here. And deep to it, you have all those dura, arachnoid, and all that. And here, just imagine there is a spinal cord running over. As the needle is being brought from behind, obviously this ligamentum flavum is the one which might provide the resistance before entering the epidural space. Okay, so remember, answer is ligamentum flavum. It's quite elastic in structure. A 69-year-old lady is brought to the emergency. The doctor reports that her mother suddenly seemed to be unable to speak. The examination reveals that the woman has a non-fluent aphasia. MRI shows a lesion in which gyrus? Unable to speak, that is motor part of the speech is lost. It is non-fluent aphasia. It is Broca's aphasia in the Broca's area. Now Broca's area is in which gyrus? Broca's area is in the inferior frontal gyrus with a Brodmann number of what? 44, 45. If tomorrow they ask you about the Wernicke's aphasia, remember the Wernicke's aphasia, also known as the sensory aphasia, is in superior temporal gyrus. And the Broca's area was in the inferior frontal gyrus. Answer is this. Let's see an image over here. This is the area for Broca's and that is the area for W. Wernicke's. Both are speech areas on the dominant hemisphere, that is the left hemisphere. Okay, numbers I already told you. A long question again. A 53-year-old banker develops paralysis on the right side of the face, which produces an expressionless and drooping experience. See, paralysis on the face. Which nerve supplies the muscles of the face? It is the seventh, facial. He is unable to close the right eye and also has difficulty chewing and drinking. Lacrimation appears normal. So lacrimation, which nerve causes lacrimation? The lacrimal gland. Which nerve causes it? It is done by the greater petrosal nerve and the ganglia is pterygopalatine ganglia. The greater petrosal nerve is a branch of, again, facial nerve. But they are saying it is normal, very good. But salivation is diminished. Now salivary glands, remember, are supplied by which nerve? You have 2-3 main salivary glands like parotid, the submandibular, the sublingual. Listen to me carefully. The parotids are supplied by the ninth nerve. And these two are supplied by the cauda tympani nerve, which is again now a branch of seventh nerve. Now they are saying that lacrimation is normal, but salivation is diminished. So, okay, this appears there could be some problem over here as well. Taste is absent on the right side. Now, taste again is carried by the cauda tympani. It also carries the taste. So, cauda tympani is damaged. That we are sure about it. And the terminal branches are also damaged because there is paralysis of the face. So you have damage to the cauda tympani, you have damage to the terminal branches. All those 5 branches which we study now on the parotid gland. Those look like damage, but the GPN, the greater petrosal nerve, is normal. Now there is no complaint of hyperacusis. Now that is done by the nerve to stapedius. All these are branches of the facial nerve. So that is also normal. These two are normal and these two are having issues. Now, audition balance normal. Where is the lesion located? Obviously, lesion is located in the facial nerve, because everything is talking over here is being talked about the facial nerve. But the greater petrosal nerve and nerve to stapedius are okay. They appear to be okay. The distal part of the facial nerve is damaged. Remember the initial branches of the facial nerve. The first branch of facial nerve is in fact the greater petrosal nerve. Then comes the stapedius. Then comes the cauda tympani, and then you have the final terminal branches. So first initial branches are okay, but the distal branches are having issues. If you look at the options, where is the lesion located? In the brain and involves the nucleus. If there was lesion in the brain, all of this would have been damaged. So within the internal auditory meatus, again, it's the beginning of the facial nerve. Not possible. At the geniculate ganglion, in the geniculate ganglion over here arises the greater petrosal nerve. So the damage was over here, then 1 and 2 would also have gone. Answer therefore remains as in the facial canal, yes, just distal to the genu. So just to the genu in the middle ear, there could have been some issue. That would have been led to this. Let me show you a couple of images. These are over here the terminal branches which supply the muscles of the face. You can see there's 5 branches over here. All these 1, 2, 3, 4, 5 which pass through the parotid gland. And here is an image showing us basically in a few branches, the greater petrosal nerve. You can see it goes to pterygopalatine ganglion, and from here it goes to the lacrimal gland. So that was okay, normal over here. And here it gives rise to now to stapedius as well. So that was also luckily normal over here. The lesion could have been possibly in the facial canal distal to the genu, because this cauda tympani was also damaged in the question, and this was doing 2 things. One, it was carrying the taste, and the other, it was supplying these glands. So there was decrease in salivation. And then from here, it comes out to the stylomastoid foramen and then supplies the muscles of the face. So from here, all these things are damaged. Therefore, this is our answer. Good question. Facial nerve branches are very important. Okay, here you can see the image for the taste sensation as well. Just for your clarity, this is the taste sensation, and if I highlight it, the spatial sensory, that is the taste, by the cauda tympani, the 7th nerve branch from here. So next question is that baseball player was hit in the base of the skull by a loose bat. He is hoarse and complains of difficulty swallowing. The cranial X-ray indicates a basal skull fracture that passes through the jugular foramen. If the nerves passing through the jugular foramen were severed as a result of the fracture, which muscle would remain functional? So what are the nerves that pass through the jugular foramen? We should know that nerves that pass through jugular foramen are 9th, 10th and 11th. So they're asking which muscle will remain functional. So which muscle is not supplied by 9th, 10th, 11th? Let us see. Palatoglossus by the 10th nerve. Sternocleidomastoid by the spinal root of accessory. Styloglossus by the 12th. Stylopharyngeus by the 9th nerve. So I guess we have reached the answer. Styloglossus, a tongue muscle that is supplied by the 12th nerve. Though palatoglossus is also tongue muscle, but that is an exception. Supplied by the 10th of the vagus nerve. Let us see an image over here. This is a cranial fossa, and here we can see as the jugular foramen over here. You can see the structure that are passing through it. These are our 9th, 10th and 11th cranial nerves, right? And there's a tongue over here. You can see the motor nerves, the hypoglossal, except this palatoglossus that we also seen, supplied by the vagus nerve, the 10th nerve over here. This was the answer. The other tongue muscles, which included the styloglossus. Next very famous question is that over here, that if you look at this arrow, a fracture at the marked arrow, there's an area that is known as a pterion. So fracture the pterion lead to bleeding of which artery? We all know. This is the cause for the rupture of an anterior trunk of which artery? The middle meningeal artery. The middle meningeal artery that leads to epidural hemorrhage. So here we have the middle meningeal artery as the answer over here. And if I ask you, it's a branch of which artery? Middle meningeal. It's a branch of the maxillary artery, which itself is a branch of the external carotid artery. So do remember the middle meningeal, and basically it's the anterior trunk of the middle meningeal artery that is just deep to the pterion. It is not over pterion, it is deep to pterion, deep inside. Fair enough. Next one, medial lemniscus is the continuation of. Medial lemniscus, when you use the word lemniscus, we are basically referring to structures in the brain stem. Now, there's a medial lemniscus in the brain stem, and they're asking it's a continuation of which structure over here? So it's a continuation of the dorsal column tracts, which are basically the fasciculus gracilis and the fasciculus cuneatus. In fact, this whole is known as the DCML pathway, the dorsal column medial lemniscus pathway, which is actually carrying the pressure, vibration, proprioception, all those sensations. And they cross where? They cross at the lower medulla. and then they go into the brainstem, they ascend up into thalamus, the VPL nucleus of thalamus, and from there they will go to the cerebral cortex, right? So answer over here is which one? It's a continuation of the dorsal column, and here you have the fasciculus gracilis as the answer over here. Okay, that's an image of spinal cord, and here you are able to see the fasciculus gracilis and cuneatus, and when they arise above, they lead to that medial meniscus. The cranial nerves are the parasympathetic component. Now we all should know the mnemonic PCS. P for the parasympathetic, C for the cranial nerves, and S is for the sacral nerves. The cranial over here is what they are asking, and it should be the tip of our tongue, 3, 7, 9, 10. Sacral over here is S2, 3, and 4. So 3, 7, 9, 10 is the answer, option number C. Remember this. This should be the tip of our tongue, 3, 7, 9, 10. The 4 cranial nerves which are parasympathetic. A 5-month-old male is brought to your office by his mother, a 5-month-old only, who noticed right-sided scrotal enlargement. On ultrasound, the enlargement is found to have a fluid collection. It's probably they're dealing with hydrocele, and 5 months could be congenital hydrocele or infantile hydrocele around the right testes. Now, this patient condition is an embryological defect, most similar to which of the following? They're asking an embryology question over here. The patient is having a hydrocele. Hydrocele is collection of the fluid around the testes in the tunica vaginalis. So imagine if this is the testes over here, and covering it, we have this the inside the visceral layer and the parietal layer of tunica vaginalis. It's normal. But here if they are saying that, okay, this fluid accumulation started over here, so there has to be some connection, right? And that connection is basically the processus vaginalis. This is the processus vaginalis. Now this would have been remained patent through the abdominal cavity or the peritoneal cavity. So fluid from here might have trickled down and slowly accumulated over here. Now this embryological basis is same for which other disease? So the fluid, if the size of the patency is very small, the fluid will come. If the size is bigger, the gut might come, and that would lead to hernia. So that would lead, now which hernia? It's a indirect inguinal hernia. Indirect inguinal hernia. So answer over here is option number C, that is our indirect inguinal hernia, not the direct, it's indirect. Indirect, remember, is more common in small children. With a patent processus vaginalis. Remember the word over here, the word is patent processus vaginalis. If the patency is small, it might lead to hydrocele. Once the patency increases in size, increase in lumen, might lead to hernia. Femoral hernia is to the femoral canal. The diaconal hernia is to the Hasselbeck's triangle. Testicle torsion is a torsion of the testes. That is a different thing altogether. Answer is our option number C over here. Here you can see the inguinal canal with the deep ring over here and the superficial ring over here. Now, inside you have a patent process vaginalis. If there is a defect, so if the fluid comes out, it is known as our hydrocele, and if the gut comes from here, it's a site for the indirect inguinal hernia, which they actually asked over here. And this is the Hasselbeck's triangle with the inferior epigastric vessel and the muscle over here, and this is the site of direct inguinal hernia, right? Okay, let's see the next one. In this case, the defect is related to failure of fusion of which craniofacial processes? You look at the image, there's unilateral cleft lip. It's a unilateral cleft lip over here. Embryology will tell us that this area is coming from the maxillary process and this area is coming from the medial nasal process. You'll see it also. So obviously the answer is our option number A, the first option over here. Answer is our option number A. It's a non-fusion of these two processes. Let us see over here. Look at the upper lip formation over here. This is the maxillary process. Yellow is the medial nasal. Blue is the lateral nasal process. And below is the mandibular process, the first pharyngeal arch. And if the cleft is being developed over here, let me show with which color, say green color over here, it is a unilateral cleft lip. Non-fusion of maxillary with a medial nasal process. Here you can see this again, the unilateral cleft lip happens on both sides. It's a bilateral cleft lip, and there is cleft lip alone over here along with the cleft palate. There is only cleft palate over here, and that's an oblique facial cleft. Remember that too, it's an oblique facial cleft. And this oblique facial cleft over here, this oblique facial cleft over here is due to the non-fusion of the maxillary with the lateral nasal process. This you might remember separately. This non-fusion leads to oblique facial cleft. Fair enough. Which of the following belongs to spatial visceral efferent column? The topic cranium nuclei is very important, and in that topic we read off all the columns. The spatial visceral efferent column is basically the column which is denoting the pharyngeal arches or the nerves of pharyngeal arches. So here you have the V3 nerve, the 7th nerve, the 9th nerve, the 10th, along with 10th you have the 11th nerve. These are the nerves of the pharyngeal arches. And do remember that the 9th, 10th and 11th, they are combinedly known as the nucleus ambiguus. Hence answer will be our option number B over here. Okay. Other options like this is for the taste, that is visceral afferent. This is your general visceral efferent, that is parasympathetic, and that is your general somatic afferent over here. This image might help you. They asked about spatial visceral efferent, right? They asked about this one. That's a blue color in this particular image, blue color, right? And this was the answer over here. This was the answer. This topic, do please revise this topic. This topic is very important. What is false about the gray rami communicans? That's about the sympathetic nerves. Now, sympathetic nerves, being autonomic nerves, have a preganglionic nerve and a postganglionic nerve. So here they have a preganglionic nerve which will synapse, and you have a postganglionic nerve. The preganglionic nerve, remember, is always myelinated, and therefore it's known as white rami. The postganglionic is normally non-myelinated and it's known as gray rami. They asking you gray rami, that is our postganglionic nerve. And the synapse where this is the sympathetic ganglion over here. So this area over here is the sympathetic ganglion. So gray rami is postganglionic. Is it non-myelinated? Yes. Is it connected to spinal nerve? Yes. Is it preganglionic? No. So that will be your answer, because they are asking you what is false. It lies middle. Yes, it lies middle to the white rami communicans. Okay. The image over here shows us these things, and let us see over here the anterior and the posterior, and from the lateral horn arises the sympathetic nerves. So if we go to the color coding, blue and red for pre and post. So blue color, that is a preganglionic over here. It will synapse over here, and from here the red one, that is a gray rami, that will come out and will be distributed to the spinal nerves. So this red one is the gray rami and this blue one is the white rami. Right? A 45-year-old woman states that she has experienced a moderate pain for 2 years over her left lower back. Pain that radiates to her left lower limb. She states that after lifting a case of soft drinks, the pain became intense. She was admitted to the emergency. Radio examination revealed disc herniation between L4 L5. Which nerve was damaged? Always remember, basic line is always say that, remember it, that if it is any two vertebrae are given, it is the lower number, that is L5, whose nerve is being compressed. Simple as that. Don't worry too much right now. Answer is our L5. Take L1, L2, L3, L4, L2, L3, L4, L5. Take C5, C6, C6 gone. C4, C5, C5 gone. L3, L4, L4 gone. L4, L5. In this question, L5 gone. Simple as that. Don't worry too much about it. Okay. Keep it as a thumb rule and don't go to the complexities. Simple as that. Examination of a 21-year-old female athlete with an injury of the radial nerve in the spiral groove would demonstrate which of the following physical signs. So injury of the radial nerve where? At the spiral groove. We have done a question on the radial nerve damage in the mid-shaft fracture of the humerus. So what happens if the radial nerve is damaged in the spiral groove? Let us see. Suppose this is imagine the head of the humerus over here, and there's the humerus coming down, right? And here you have the radius over here, and here you have the whole ulna over here. Fine. There is a lateral medial side. Radial nerve, let us say, it goes like this. There goes behind, then comes over here. Then one of its branch goes behind, one comes in front, and they all do like this. Injury is where injury is in the spiral, the radial groove or the spiral groove. Which of the following will be present? Will there be weakness of thumb abduction and thumb extension? See, thumb abduction is done by abductor pollicis longus, abductor pollicis brevis. Extension is done by extensor pollicis longus, extensor pollicis brevis. Most of them are supplied by radial nerve, very right. But like this, ABP is supplied by the median nerve. abductor pollicis brevis by the median nerve. So there will obviously be weakness in the thumb abduction and thumb extension. So which nerve supplies them? It is the posterior interosseous nerve, which is a branch over here. So if the radial nerve is damaged over here, this is the site of injury, that is the site of injury. So option A will be definitely present. Let's see other options. Weakness of thumb opposition. Thumb opposition done by opponent's pollicis. So that is supplied by which nerve? Median nerve. So that will not be there. Inability to extend the elbow. Now see what happens is, radial nerve, as it before it goes to this radial groove, it already gave off some branches to the long head of triceps and the medial head of triceps. So yes, there will be weakness in the extension of elbow, but there would not be inability to extend the elbow. In place of inability, there might be weakness, not inability. Therefore, again, we can rule this out. Paralysis of pronation of hand. Now, pronation of hand is done by pronator quadratus pointer teres. If you know which nerve supplies them, pronator quadratus supplied by the anterior interosseous nerve, branch of median nerve. Teres supplied by directly median nerve. So obviously, this will not be possible. Answer is our first option only, option number A. This is how we can approach questions like these. Here the radial nerve is being shown over here, and let me tell you again, already few branches are given from radial nerve before it reaches the radial groove to the triceps. So there will be weakness in extension of the elbow, not inability. These are thumb movements. Go through these movements as well. Practice on your own thumb. The question might come as an image format that which movement is being done over here. A 45-year-old male is treated at the hospital after he fell from his bicycle. Examination reveals fracture of both tibia fibula. On examination, the patient has a foot drop. Which leg compartment muscles are not working? If there is foot drop, anterior leg so there's anterior leg compartment muscles not working, but normal eversion. So anterior leg compartment muscles minus, eversion is by the lateral leg compartment plus, they are working. Anterior leg compartment, which nerve supplies it? Deep peroneal nerve, we discussed it. The lateral by superficial peroneal nerve. So which nerve is damaged? Deep peroneal or the deep fibula. Option number D over here, straightforward. If they would have said that there is a loss of eversion also, then we would have gone with both of these nerves are damaged and both are branches of common peroneal nerve. Then we would have thought of option number B. But here the eversion is normal, so this is normal, this is normal, this obviously is normal, this is the one that is paralyzed or damaged over here. This is showing us the branches of common peroneal nerve into deep and the superficial peroneal. You can see the deep peroneal anterior leg, superficial goes to the lateral leg. Okay, here you can see again the deep peroneal nerve over here and how it is supplying all the anterior leg muscles. So if all these are paralyzed, there will be going to be foot drop, or what do we also call it as? Foot drop, high stepping gait. It's also known as high stepping gait, because obviously you have to take steps has to be more higher in height, right? Because the toes, you don't want your toes to be rubbing against the floor. So it's known as high stepping gait. Fair enough. Again, these muscles over here now. The next question, 30-year-old female is presenting with wrist pain on the lateral side. On examination, the following test was positive. Tendon sheaths of which muscle? It's a case of your decurvent stenosynovitis. Decurvent stenosynovitis, which involves the lateral boundaries of the anatomical snuff box. Okay, and those are found by abductor pollicis longus and extensor pollicis brevis. And therefore, our answer is option number A. Remember, these are the lateral boundaries of anatomical snuff box, lateral boundaries. And test over here is Finkelstein test. Test over here is Finkelstein test. Okay, very common problem. Do remember it. Here you see the anatomical snuff box. This radial artery is the only content of this box. Identify the cells marked in this logical image. Let me put some yellow arrows as well. It's a cerebellar cortex, and these are very frequently asked. You have a molecular layer over here. You have a granular layer over here, and between this, that's the answer. You have the Purkinje cell layer over here, which are one of the largest cells in the CNS. Purkinje will be the answer, should be one of the options. Here it is. Frequently asked question about the cerebellar cortex histology. Here you can see this detailed, and this over here I have highlighted already, the molecular, the Purkinje, and this is the granular cell layer, and this is what they have asked multiple times, so don't miss it. Okay, it's a famous PYQ. A 43-year-old male is admitted to the hospital complaining of diplopia when walking down his street. Now, this line automatically tells us problem in the fourth nerve. Let me tell you beforehand. Okay, now diplopia when walking down stairs, when reading newspaper, that will be the typical history. During examination of the extraocular muscles, the patient experiences diplopia, and when he is asked to turn his right eye inward towards his nose and look down, he is able to look inward but not look down. Fourth nerve supplies which muscle? SO4 LR6. Fourth nerve supplying superior oblique. Superior oblique basically helps in looking down. Superior oblique. Apart from causing intorsion, that will be the main action of superior oblique. It's basically intorsion. It also helps in looking down. So which nerve? We already told from the first line itself, things should be crystal clear that are dealing with the trochlear nerve. Now let me show you a few images over here. This is a superior view with the roof of the orbit removed. You are looking at a superior view of the right eye, and that's a lateral view of the left eye because you are seeing the lateral rectus over here. And these are the muscle actions. Obviously, this is the right eye that we are looking, and here's a superior oblique looking down and also intorsion. Okay, so do remember this superior oblique part. Okay, 70-year-old is admitted to the emergency with a severe diarrhea. An arteriogram reveals 90% blockage of the origin of inferior mesenteric artery from the aorta. If I ask you, the inferior mesenteric artery comes from which vertebral level? It is L3. Now the question is, which artery would most likely provide collateral to the descending colon? Let us try to understand this. This is our, say, the transverse colon, right? Then this is the descending colon. Then this is, say, sigmoid, and this is, say, the rectum over here. Let me label it transverse colon, descending colon, sigmoid colon, and the rectum. Inferior mesenteric artery supplies the hindgut, and the hindgut includes the distal part of the transverse colon, descending and everything over here. So you have the branches which are running like this and all their subsequent branches. If I would like to name the branches, there is the left colic artery. This will be the sigmoid arteries, and that will be the superior rectal artery. I'm highlighting these three branches of inferior mesenteric artery over here: left colic, sigmoid, and superior rectal. They are saying that this IMA, inferior mesenteric artery, is 90% blocked at the origin itself. Which artery would give blood to the descending colon? Now here blood will come from where? Blood will come from where? Obviously blood will come from an artery that is running in the proximal part of transverse colon. Which artery is that? It is a branch of the superior mesenteric artery known as the middle colic artery. Because it is a branch of SMA which is normal over here, therefore middle colic artery will be the best answer over here. But there is also marginal artery of Drummond. All of these arteries, if you recall, all of these arteries, they form a collaterals over here, anastomosis over here. Marginal artery of Drummond, arc of Riolan, all of that. So the middle colic artery will give some blood to the descending colon, might reach the sigmoid or not, but at least descending colon it will definitely reach. Okay, answers are option number B over here. Thyroid mass move with the swallowing because the thyroid gland is enclosed by which of the following fascia? Basic question in the head and neck, where we talk of the deep cervical fascia as an important topic. The thyroid is lying in front of trachea, and in front of trachea we have a pretracheal fascia which also covers the thyroid gland. Answer has to be undoubtedly the pretracheal fascia. Carotid sheath we have discussed, that is covering the carotid vessels. The investing layer of deep cervical fascia, it actually covers the sternocleidomastoid and trapezius. The prevertebral fascia is present quite deep and it covers the vertebrae, cervical vertebrae. Answer is pretracheal. Let me show you with the help of an image also. This is anterior and posterior part. Don't look at everything, just focus on what I'm trying to show you. This is the red colored thyroid gland, if I may put it like this, thyroid gland. And look at the pretracheal fascia, another red box over here showing us the pretracheal fascia that is covering the thyroid and goes in front of trachea. This is the trachea, right? Known as the pretracheal fascia. Okay, hence the answer pretracheal fascia. The attachment of which of the following fascia prevents the extravasation of urine during the urethral rupture in a superficial perineal pouch into the thigh anal triangle? What are this trying to ask us? That there is urethral rupture in the superficial pouch. Urine is not going to thighs or the anal triangle, due to which structure? There has to be some facial attachment over there, and that facial attachment is Colles fascia. It is attached to the perineal membrane. We'll show you how, and that is preventing the urine to go to anal triangle. And also remember the Colles fascia, it is a remnant of scarpas in the pelvis. It is fused with the fascia lata, and that is known as your Holden's line. That is known as the Holden's line, and it prevents the urine from going into the thigh. So this fascia becomes very, very important in the pelvis and perineum region. Answer has to be the Colles fascia. Let us try to see it over here. This is where they are trying to show us the Colles fascia. This is, you can see the scrotum and the penis over here, and the urethra will come like this, urethra will come like this, and imagine the urethra is ruptured over here, so your urine is coming out over here, right? But it is not able to go posteriorly, not able to go below, due to attachment of Colles fascia, one to this point over here. Let me show this purple color point over here. Second point not able to show, but that is located lateral to the pubic tubercle, Holden's line. Okay, facial lata attachment. During a splenectomy, when you remove the spleen, injury to which of the following ligaments can lead to complication of pancreatitis? What is the relation of pancreas to spleen? How can the pancreas be inflamed or be irritated while you are removing the spleen? The spleen is an intraperitoneal organ and it has few ligaments. In front of a spleen, we have the gastrosplenic ligament. Behind the spleen, we have the splenorenal ligament. So what is the role of pancreas? Pancreas, remember, is a retroperitoneal organ, so it has to be present behind the spleen, right? Now, if you look over here, the gastrosplenic ligament, the contents of the gastrosplenic are basically the short gastric vessels and the left gastroepiploic vessels, while the content of splenorenal or the linorenal ligament are the splenic artery or the splenic vessels and your tail of pancreas. Therefore, if you are removing the spleen, you have to obviously cut the ligaments. While cutting the splenorenal ligament, there might be a case when you have damaged or pancreas could be damaged leading to its inflammation. Therefore, splenorenal ligament would be the answer over here. Beautiful question over here, right? So remember the contents of the ligaments as well. Okay, here they are trying to show us about the spleen location over here, and if I may tell you that this is the linorenal, which is also known as the splenorenal ligament, and the pancreas will come like this, and the tail will go into the splenorenal ligament. That is the location of pancreas behind the stomach also, because it is part of the tail or the part of the stomach bag, and the tail going to the splenorenal ligament. An elderly man with atherosclerosis presented with abdominal pain and blood-stained stools. CCT abdomen is suggestive of ischemic colitis at the splenic flexure involving the marginal artery Topmost. See what happens. This atherosclerosis, CCT is showing us ischemic colitis. Ischemia means decreased blood at the splenic flexure. What is splenic flexure? We had the transverse colon, we had the descending colon. On the left side here, we have the location of the organ, that is the spleen, right? This is the splenic flexure over here. So they are saying that the ischemia, this decreased blood over here, what are arteries contribute to the formation of this structure? Now, just a while, 3-4 questions back, we discussed a question on the 90% blockage of inferior mesenteric artery. The branch of IMA that was coming from here was the left colic artery, remember. And the branch of superior mesenteric coming from here was middle colic artery. So obviously these two are the ones that are going to anastomose at the splenic flexure. They are going to form the arteries over here, and therefore the answer will be this only. Left colic and middle colic, option number C. Left colic here is a branch of IMA, and middle colic is a branch of superior mesenteric artery SMA. Hindgut and midgut. Okay, keep that simple. All of the following structures arise from Wolffian duct except. Wolffian duct is basically this duct which is forming mainly the male genital duct. Okay, it's also known as a mesonephric duct. Okay, so which is not derived from the Wolffian duct. Proximal part of prostatic urethra in males, yes, it is derived. Definitely, it is derived. Prostatic utricle in males is a remnant of the paramesonephric duct. Paramesonephric duct, that is also known as Mullerian duct. Okay, so prostatic utricle And there's also one more structure, and appendix of testes. Don't forget this. And appendix of testes. These are two structures in males which are remnant of Mullerian duct. I am highlighting this: prostatic utricle and appendix of testes and Mullerian duct. Mullerian duct is a female genital duct derivative. In males, it gives rise to mainly these two structures. So remember this. Rest of these two things, they are coming from the Wolffian duct. So answer is our option number B over here. An infant has a noticeable small mandible and cleft palate. CT reveals hypoplasia of mandible and defect in the middle ear and tympanic membrane. Developmental defect of which I hope you will answer this, because we just studied the first arch gave rise to mandible, and in that question we saw the image also. It gave rise to two bones in the middle ear, which were our malleus and incus. It's a first arch, without a doubt. It's a first arch. Option number A over here, meaning the first pharyngeal arch, will be definitely our answer. Here you can see the Meckel's cartilage, the malleus incus. This color is for the first pharyngeal arch over here. Question just asked. Here you can see this question we have done previously also. I guess the question was about the muscle, masticatory muscle, coming from which arch. In previous question, this was the point over here. The rotation of the midgut is primarily based on the axis of which of the following? Now, remember that this midgut rotation, in which there is a 270-degree anti-clockwise rotation. There is a pre-arterial loop and there is a post-arterial loop, and between we had a vessel that came out from here in the umbilicus. This is a midgut loop. So which is the artery of midgut? Superior mesenteric artery. Axis will be from which artery? Superior mesenteric artery. Is that in the option? Yes, so that is the answer. No confusion. It's a midgut loop. It's a midgut artery, superior mesenteric artery. So the axis will be around the superior mesenteric artery. Okay. Okay, one more. Probably the last one. I hope you are enjoying. I'm a little bit stressed, but time is less. Revise more, and all the best, and keep on revising. A 60-year-old child was diagnosed with a tumor involving the superior cerebellar peduncle. Neuro question: the structures passing through the cerebellar peduncles are very important. Which tract may be likely involved by the tumor? So what passes through the superior cerebellar peduncle? Normally, see, there is superior, middle, and inferior. These are the three cerebellar peduncles. They connect to what? They connect to the midbrain, the pons, and the medulla oblongata. And this is, imagine the cerebellum is over here. The superior cerebellar peduncle will be actually connected to the midbrain. That will go above into the cerebrum, or you can say the thalamus, dentatorubro-thalamic tract, all that. So they are saying cuneo cerebellum. Now cuneo is what? Cuneate nucleus coming from below. Olivocerebellar, olivary nucleus coming from below. So they're all coming from below. Then you have spinocerebellar. They're also coming from below. Then what will be the answer? It is the anterior spinocerebellar, which is actually an exception, though it is coming from the spinal cord. So it should have been entering through the inferior cerebellar peduncle. But only the posterior spinocerebellar tract enters through the inferior cerebellar peduncle. Anterior one is an exception. It enters through the superior cerebellar peduncle, and the answer is famous PYQ over here. Don't forget it. And apart from this, read all the connections of the superior cerebellar peduncles in middle and inferior and what passes through it. Remember, middle is for the pons, so basically you have the pontocerebellar fibers over here, right? That was all. I hope you enjoyed. Keep on revising. Any query in doubt, do reach out to me in all the social media handles as well. You have all the Facebooks, Instas, anywhere you can reach out. All the best, and that's all. Thank you.